Oh, Vanessa, I think you're on mute.
Thank you. Hi, everyone. Welcome. Today's webinar is on best practices for serving trans women with prostate cancer. This is in recognition of the fact that June is Pride Month, and we are proudly co-hosting this as part of the Prostate Cancer Impact Alliance, which is a diverse stakeholder group of about 40 different members, mainly patient advocacy groups, all committed to ensuring patient care in the prostate cancer space is the best it can possibly be for all individuals living with or at risk for prostate cancer. The PCIA is convened by the American Urological Association and the Urologic Care Foundation. Of course, we at the AUA proudly stand with patients. We recognize we are nothing without the patients we serve. So we're thrilled to be here today. All right. Thank you to our sponsors. They are listed here. We really would not be able to do it without our industry partnerships. Okay, a couple of housekeeping things before we dive in. So we have a lot of great panelists, as I'm sure you're aware. So I imagine that you'll have questions throughout the conversation. Please enter them into the chat box. We anticipate enough time at the end to answer at least a few questions. Any great questions we'll try to answer over email and a follow-up bundle of materials that will go out. If you have any technical difficulties, please email Dominique Henderson on our team. She is our tech go-to. And then that last bullet there is a follow-up. We have prepared a one-pager for you to hang in your office or for you just to keep as a reference on some of the best practices that we'll talk about today. All right. So we have 5 panelists. We have Dr. Jennifer Anger, who is a professor of urology and vice chair of research from UC San Diego. She'll be speaking from the provider perspective. And then we also have Dr. Farnoosh Nikad. She is a resident physician with the Department of Urology at University of California, San Francisco. So 2 Californians. And then speaking from the patient perspective, we have Dr. Glass, Bobby Glass, who is a longtime trans rights advocate. We have Daryl Middledorf, who is founder of Male Care and the National LGBT Cancer Project. And joining us, hopefully a little bit later, we have Eve Gamble, who is a transgender woman with prostate cancer. Then we have our agenda at a glance over to the left. So it can be broken down into 3 parts. We have an hour and a half, so a long time to dig in. The first part is going to be Dr. Nikad giving her research findings, a summary of her findings from research in the prostate cancer in the trans population in the VA. This is research that was presented at the recent AUA meeting. It razzles, it dazzles, it's very impressive. So it's going to be a great way to set the stage for the conversation that follows. Then we have a handful of panel questions and we'll do round robin answers for those. And then at the end, we have some best practices presented by Daryl Middledorf based on his poll findings and in administering patient support groups for LGBTQI+ patients. And then at the end, as I said, time for Q&A. So please keep those questions coming in the box throughout the conversation. So to kick things off, I'm going to turn it over to Dr. Nikad.
Thank you so much for that very kind introduction and for the honor of presenting our work with you today. Our group is very interested in understanding prostate cancer in transgender women and ultimately how we can best care for transgender women with prostate cancer. This is the rest of our team, including Dr. Anger, who's also on this panel. Next slide, please. Transgender individuals remain one of the most marginalized groups in our society. Tremendous progress has been made in recent years to decrease the discrimination and marginalization affecting this group, and as such, the number of individuals openly identifying as transgender is projected to increase. Transgender women, or people who identify as women but were assigned male sex at birth, retain their prostate even after gender affirmation surgery. Thus, it's important for all clinicians to know that transgender women remain at risk of prostate cancer. Next slide. Previous literature on prostate cancer in transgender women was limited to only 10 case reports and very few other studies. The overall incidence of prostate cancer in transgender women also remains unknown. Next slide, please. Given the tremendous lack of primary literature, our group sought to conduct a national study describing prostate cancer in transgender women, specifically focusing on prostate cancer characteristics at diagnosis, and to estimate the number of cases of prostate cancer per year in this population. Next slide, please. To accomplish this, we performed a retrospective study of adults ages 18 and older between January 2000 and November 2022. Patients with both an ICD code for prostate cancer and an ICD code related to transgender identity were queried. Now, there's no specific ICD code for transgender identity, so we use 13 ICD codes related to transgender identity that we have previously determined to be both sensitive and specific. Detailed chart review was then performed to verify transgender identity and prostate cancer diagnosis details, including clinician notes, medications, gender-affirming hormone therapy usage, PSA values, and prostate biopsy details. Next slide. A total of 155 patients were confirmed on chart review to be transgender women with prostate cancer. Estrogen was by far the most common gender-affirming hormone therapy used, so patients were stratified by their estrogen usage. 116 had never used estrogen, 17 had formerly used estrogen and had stopped at the time of prostate cancer diagnosis, and 22 were actively using estrogen at diagnosis. Next slide. The median age was 61. Most patients were white with only 6% Black, and median PSA was about 7. The overall duration of estrogen use was 32 months among estrogen users. We expected 33 cases per year using cisgender male estimates. However, using the median year of transgender code entry, which created about 11 years of follow-up, and a previous estimate of 10,000 transgender women within the VA, we ultimately had 14 cases per year per 10,000 transgender women. So just under half the rate of that is seen in cisgender men. Next slide. Next slide, thank you. Notably, median PSA density, which is a measure of prostate cancer aggressiveness, was highest for those on estrogen at diagnosis. And if you can hit next slide, there's an increasing trend as shown here. Next slide. Additionally, the highest percentage of grade group 5 disease was seen in patients on estrogen at diagnosis at 29%. This is compared to only 12% for never estrogen users and 6% for former estrogen users. Now, as a point of comparison, roughly 16% of cisgender male veterans have grade group 4 or 5 disease. Next slide, please. And one more, thank you. In conclusion, prostate cancer does occur in transgender women and is not as rare as published case reports may suggest. Nonetheless, rates were lower than what was expected. Finally, though our numbers were very small, there were trends that transgender women actively on estrogen had higher rates of grade group 5 disease and higher PSA density, both of which suggest delayed diagnosis. Next slide, please. Now, lower rates of prostate cancer may ultimately stem from a number of factors, including lower rates of PSA screening, lack of awareness of prostate cancer risk by both clinicians and patients, the suppressive effects of estrogen on prostate cancer development and biology, and prostate cancer ultimately being missed in transgender women due to misinterpretation of, quote, normal PSA levels in those on gender-affirming hormone therapies. PSA reference ranges are all set based on data from cisgender men, but transgender women on gender-affirming hormone therapies would be expected to have significantly lower PSAs. Thus, a normal PSA value in a transgender woman on estrogen may actually be very concerning and warrant further evaluation. Future work should aim to establish the prostate cancer incidence in transgender women formally and aim to establish baseline PSA values in transgender individuals as a function of gender-affirming hormone therapy type and duration, and to ultimately create guidelines on this subject that are specific to and inclusive of transgender women. Next slide, please. And with that, thank you very much for your time, and a huge thank you to all of our co-authors and to my mentors who made this work possible. If you'd like to read the study, it was recently published in JAMA, and we're happy to answer any questions. Thank you.
Thank you, Dr. Nikad. And I'm sure you do have questions, and we'll get to those at the end, but this was really great and a great framework for the conversation to follow.
Thank you.
The next question, and to kick things off, we're going to turn it over to Eve Gamble, who is a trans woman and a prostate cancer survivor, and she is going to share her story. So without further ado, Eve, take it away. Tell us about your prostate cancer diagnosis, how you knew to get screened, what happened next, and how your identity as a trans woman came into play, and how your care team recognized or didn't recognize this identity, as the case may have been.
Oh, wow. That's a heavy question. And I apologize for being late to the webinar. I got my time zones confused. And we were an hour earlier than I thought we were going to be. And I should have been paying closer attention knowing that. However, I'm grateful to be here. It's an honor, actually, a dubious honor, because prostate cancer is not something that anybody really wants or thinks about. And so, how did my prostate cancer happen? I don't know. It was genetic. It came into me. But I got diagnosed in 2017, in late 2017, when my prostate cancer in 2016 went up to 4 to up to 11 in 2017. And I got referred to the urology, and I had the biopsy, and as humiliating and invasive as it was, they told me that I had aggressive cancer, and it was the Gleason 9, and I elected for surgery as opposed to radiation or proton therapy. But I did that, and when I got diagnosed, it's important to note that it was before I transitioned, and it was after my cancer diagnosis that I decided to transition, because and particularly after the surgery, demasculated me in the ways that surgery usually emasculates men. So this is where I am. I did tooth surgery and radiation because it had escaped from that. So it was advanced, and then it was determined castrate resistant. And I did the leprolide, and then I did an orchiectomy after that. And nothing seemed to get it under control, but the cancer had not metastasized to my bones or any other organs yet. So I decided not to, well, I didn't need to do anything after that, but I went on abiraterone. And how did my identity impact my treatment? Right?
Yeah.
I'm trying to look at the screen, and I should have my question list in front of me. But it did. I had some of my doctors be very empathetic, but the system was a long way from perfect for me. And so did my urologist recognize my steps? Not so much. I don't think so. I think that I was the only one that promoted myself as a trans woman.
And Eve, if you could speak to kind of in those initial encounters as you were going through this, what constituted a good experience as a patient, as a trans patient, and what constituted a bad experience? And I know we're going to get into this further in the conversation.
Oh, yeah.
I also understand, right, that
a negative experience was being misgendered continually when I would go to the urologist, or when I first went to the urologist, to the oncologist. I had one oncologist who was very empathetic with me. Her name was Dr. Yvonne Seda, and she wrote a story about me within the Journal of Clinical Oncologists. But typically, there's been no response from the urologist office. I'm continually mispronounced, and it's
Actually,
disappointing.
that's a great segue to the next question, which is, why are preferred pronouns and other elements of a gender-affirming environment important, and how does this tie into the larger concept of patient-centered care? So this question, the first part is going to go to Dr. Glass. Are you there, Dr. Glass? Well,
yeah, let me unmute myself. Thank you so much for inviting me. I have no personal experience with prostate cancer, and I don't want to, but I have been very active. I'm the co-director of the Transgender Wellness Coalition in Louisville, and I work very closely with the medical and mental health professionals. And our city is actually a city where transgender people thrive, and it's really quite the oasis. Kind of like the blueberry and the red soup when you look at where we live in the South, but life is good in Louisville. And misgendering it's really difficult for people who aren't trans or non-binary to understand what a big deal that is for us. I work with public schools and colleges, and the number one, this population is just classically overridden with anxiety and depression, and being misgendered only contributes to all of that, and just really contributes to the high suicide rate and suicidal ideation and all of that, because here you are trying to make this bold statement and live life true to yourself, and a lot of times your environment is just going to really try to sabotage all of that. And so when you go into a doctor's office, you should have indicated your preferred name and pronouns when you made the appointment, but if you haven't done that, you can't expect anybody to know more than what they've got before them. But as quickly as it can be corrected, it really needs to be. And there's so many people that work in a doctor's office, and you may have very sympathetic physicians, but the office staff and the receptionists maybe haven't gotten that message yet, or they're brand new and they haven't been introduced. And so here you've got a transgender person in the waiting room. They were very uncomfortable to make the appointment to start with. They didn't want to be there. They don't know what they're walking into, and then to be misgendered once they get there just really adds insult to all that injury. And it, here you want somebody to come in and have a positive experience and attain the highest degree of wellness, but that's such a kick to be misgendered, and especially if you're in a waiting room and there are other people there, it's humiliating. And so you really have to be very sensitive to that, because they're people who were just the sex assigned at birth. It's like, you just look at what's between somebody's legs. You don't look at all that's between their ears, and that's really the biggest sex organ when you get to it, is what's between your ears. And so it's a tough battle trying to come into all of that.
Thank you, Dr. Glass. That's a great answer. It makes me think, I feel like I've read somewhere, I think it was the Washington Post piece over the springtime, that, misgendering has such an amplified effect that it can, result in chilling a patient's interest or even going to a provider for years thereafter. So I think it is important. And I think, oh, go ahead, Eve.
Oh, thank you. It just hurts when somebody misgenders you, and you do everything you can to present your authentic self, and somebody reminds you stingingly that they can't accept you, or they don't believe you as that authentic self. It's like death by 1,000 needles. Each time they hit you, it hurts a little bit. And I would like urologists and urologist offices to be more cognizant of that.
That's a great segue to Dr. Anger, actually, who has developed an area of expertise in this space. So I'm going to turn it over to her to answer the second part of this question. What steps can urologists take to ensure their offices are trans and LGBTIA friendly?
Thanks so much. If we could just move to the next slide, please. And I think what's important is that we don't all have to be members of the LGBTQIA community to be able to provide good care. And I myself am someone who trained in reconstructive and female pelvic medicine and reconstructive medicine, which was typically, I guess, male, cis female, but it gave me this reconstructive background. And I actually had very little interaction with the trans community before I saw a colleague of mine at Kaiser in Los Angeles performing one of these surgeries. And I thought, this is really what I want to do. This is a perfect use of my skill set. And someone actually said to me, well, I don't see you doing any ally work. You're not an ally. And I kind of ignored them, but I listened to them. And I actually have become an ally through working with the wonderful population, but I really had to learn a lot of this from scratch. And so I like to encourage urologists who maybe think, well, I don't know the community, I can't do this. And I like to encourage urologists that they can do this, and it's not that hard. And we do make mistakes, and there's way to address mistakes. And I find the trans population's very understanding of that as long as we're making effort. So how do we start? And not on this slide are a couple simple things that we did in our office. One is one of my offices is a urology office. That's easy. Another office is the female pelvic medicine center. And so we changed that. And luckily all the doctors in the group those who see trans patients and those who don't, were happy about changing the name of the clinic to Pelvic Medicine Center. I've seen our office mate who performs semen analysis studies. Our trans women have to go to it's a men's health clinic, but ways to get around that are having a trans inclusive day so that trans women can go provide semen analysis on, let's say, a separate day. The other thing that we did, which was also pretty easy, change the bathroom signs, not too hard. And so that was easy. We just have non-gendered bathrooms, and that's literally a matter of just a couple signs. So that was easy too. So what else can we do? And we're at UC San Diego Health, the urology suite, and this is in Hillcrest, which is really the kind of hub of our LGBTQIA community in San Diego. Did someone comment? I hope I'm not missing anything. Anyway, so they go into the hospital to then go to our clinic. And that's where things can get tricky, because you have patients go to get get told to go to the clinic. And I had a patient where they got her name wrong in the clinic when my patient checked in the main hospital. And she said, they got my name wrong. And I'm looking at her badge and it said neurology. And I thought, well, they can't even get the office right. How are they going to get your name right? And it's like, it is sort of upsetting as a provider when you feel like how can we fix all levels of the hospital? And I just want to throw in an exciting endeavor that we are involved in now, which is a patient safety learning lab. So we got funding through the American Agency of Healthcare Research and Quality, which is AHRQ, to help identify these big system problems to help. So there's a much bigger problem related to misgendering trans patients, but we start at our office.
That's wonderful, Dr. Anger. This is for a system-wide kind of reform in the name of pushing things forward, making it the space more trans friendly.
Exactly. But identifying like at what levels do things go wrong?
Sure.
You know, because as was just discussed earlier, that misgendering causes patients not to want to come back. And so
For years, it seems, from the things that I've read, like the sort of lasting trauma of that is huge.
exactly. And so little ways to change our medical intake forms so that they have, and we don't even use the term preferred name, it's what's your name. Because preferred implies that it's a preference, but it's actually a name, right? And then so these different medical intake forms that take into account identity, and then health flyers, you know, kind of, we even have little flags that we have hanging in our office. So there's different ways to make it a trans-friendly place. But
that was a great, oh, go ahead. I'm sorry.
So like, even if you can see here, people have little pins or pronoun buttons that say what my pronouns are. Even providing name tags with pronouns that they can put on. And then, and when I meet a patient, I said, what is your name, or how do you like to be addressed? Because sometimes we have in our electronic health record, it's designed to be inclusive, but it's not always correct. And so as we transition into a gender-friendly electronic medical record, we still need to have safe proof, like safety mechanisms. So I never go into a room without, like, you know, if it looks very, like if I'm not sure I'm have the correct name, I'll just say, may I ask, how do you like to be called? And I'll say, like, do you use, what are your preferred or what are your pronouns? That's, again, we don't say preferred, but what are your pronouns? And then I'll say mine or she, her. And patients often say thank you. Like, they're just, we have a wonderful program manager who's non-binary and uses they pronouns. And for people and patients who use they pronouns, people who are not familiar with pronouns tend to get the they pronouns incorrect. And so ways to practice are just calling everybody by they pronouns, just to practice for a day. And what our program manager said to me was that it's not that they feel that the person's being mean by getting their pronouns wrong. They just don't feel that they're being seen. Yeah. And that was a really kind of helpful for me to get the pronouns, you know, to really focus and make an effort on making pronouns like correct and using correct pronouns. The other thing, and I learned from one of my kids who's 17 now, but when she was 15, they had a teacher in their class, and this is a progressive school. They had a teacher in their class use pronouns, and it allowed a transgender boy who was like just beginning the transition to say, I use they pronouns. And so it just was this very kind of concrete example of when we're pronoun friendly, it gives people room to be who they are and and so I think even though there's a lot, you know, you can hear on, you know, different sides, why do we make such a big deal about pronouns, right? And I don't think people who are from that point of view are really going to be on this Zoom to begin with, but I think it's important when that we explain like the importance of pronouns, because even though they seem, well, it's not a big deal, it actually really does create an environment that's trans friendly. And then the last thing I just want to say is, if we mess up, and we do, and we have trans providers, so they're transgender themselves and they provide trans care, they've messed up patients' pronouns, right? And so they say, you apologize and you get it, you say the correct pronouns, and then we move on. So we don't have to go like flogging ourselves, but we just say, I'm so sorry. Or I'm like, oh, I'm better than that. And then we move on.
Sure.
And so, and then the last comment I just want to say is, our office staff do need trainings, and WPATH provides trainings. We can provide a training if you want, anyone really on this call. but we provide trainings for staff who are new to this sort of kind of the terminology and ways to make an office trans inclusive. But it's also important that to be trans inclusive on the telephone, because trans women, you know, who've lived as women for a long time can get misgendered if their voice is on the lower side, if they may, you know, if they have masculine sounding features on the phone, they're often misgendered on the phone. So the office staff who is answering phones need to be very careful about using gender neutral pronouns, because it's, you know, we don't assume one's gender based on the tone or the pitch of their voice. And I think that those little things are a really great start. And again, just knowing that you don't have to be in the LGBTQIA population to provide orchiectomy, for example, to provide general urologic care. And I think the more people that we have who are allies, the better, as there's a lot of need for gender affirming surgeries. And I think all of us in urology know how to do an orchiectomy. And I think there's ways that any urology office can become trans inclusive.
That's
Anyway,
great. Thank you so much, Dr. Anger. One thing that has already emerged as a theme here is ask questions. Ask your trans patient, ask your non-binary patients. No one will get mad. In fact, to the contrary, they'll be appreciative. So the next slide. So we're going to do a round robin on answers here. So as we've established, transgender women, no matter what gender affirming surgeries they may or may not have had, have prostates and are at risk of prostate cancer. And yet this risk commonly goes unacknowledged by both the affected population and their doctors and the general public. What efforts are needed to spread this message and to close gaps in education and awareness? I know, Dr. Anger, you talked about some stuff at the provider level, but to kick things off, we're actually going to throw it to Daryl, and I'm going to have him speak from the psychosocial perspective, because I feel like he's got his finger on the pulse when it comes to where the biggest gaps are. So Daryl, what targeted efforts are needed? What would this look like?
Well, there are a number of targeted efforts, but I just want to return to a couple of previous things. I mean, when we're talking about, you know, gendering and such, I mean, it's a very simple concept. Why would you want to hurt a patient? You know, just think like, I want to help this patient. What can I do to help this patient? One of the things I can do is to make sure I know what pronoun, you know, how to call them, you know, and how they would like me to call them. It's a simple construct, and that's a construct that can, a targeted construct, a targeted intervention that can be appreciated by people from well across the political spectrum. Dr. Anger mentioned, and I think probably correctly, but still I don't want to exclude those who are struggling with this seminar or webinar and saying, oh, these folks are woke or whatever, you know, pejoratives they're using. The idea of what we're talking about today isn't so much political or pushing an agenda. It's just about being nice, you know, being a good clinician. You know, when I have a patient come into my office, and it's a social work office, so I'm doing, you know, psycho-oncology, I want to express that this is a safe place, a caring place. I'm a caring clinician, and both of my ears are open. And that's the beginning, middle, and end of it. You know, the agenda stuff and political stuff you could save for a later day, but we're talking about medical care and healthcare, and that's really the framework for a lot of this.
Basic dignity. I like that. I like the way that you described that. It's basic.
And that sort of goes now to this set of questions. You know, what are the what do we need to spread a message? And I think one of the misunderstandings we in the oncology world and in the specific to urology is that some cancers are non-binary. You know, breast cancer affects men and women. Prostate cancer affects men and women. And even though there may be somebody yelping in in the virtual audience saying, no, a woman is a woman, these are not women, these are returning to their chromosome definitions or whatever. They're women. Women have prostate cancer, men have prostate cancer. So like at Male Care years ago, we used to call our one of our taglines was men fighting cancer together. And we changed that to people fighting cancer together. And our board was very concerned of the reaction we would get. Would it be comparable to today's, Bud Light beer boycotts and such? But no, I mean, patients understood what we were talking about. It's about compassion. It's about understanding the brother and sister that you have that's sharing your disease. And that's the kind of understanding that needs to be conveyed and diffused throughout every adult population. One of the things that I think contributes to disparity is when a community denigrates something that is unusual to be identified with them. So when Male Care started 25 years ago and was focused on gay men and prostate cancer, the National LGBT Cancer Project started in 2004, focused on the entire community. The idea that HIV and other issues, lung cancer from tobacco abuse, popper abuse, all sorts of alcoholism, depression, anxiety, suicide rates. These are the paramount issues of our community, not cancer, and specifically not prostate cancer. Well, cancer is a disease that's owned by an individual, and we all have to respect every individual that comes into our offices, comes into our living rooms and says, my goodness, I was diagnosed with this disease. I don't know what to do. And to have a hug and a rub on the shoulder from both male and female members of what we consider our family, who we consider our friends, and who we consider our healthcare providers. The idea of allies, I think, is interesting as well. And maybe it has a toxic quality in that it separates the healthcare provider community from folks who consider themselves allies, which I imagine every clinician on this call, and those who are not allies, who are saying, who wouldn't, don't call me that, I don't want to deal with that. Well, we're providers of healthcare, we're providers of care, and ultimately we care about the person sitting in front of us. And we care about the people we don't know. I'm in New York City. I care about the people in Oshkosh. I care about the LGBT community in Waco, Texas, and Madison, Wisconsin, and in Uganda and other countries that have very strong provisions against coming out as LGBT and living your lives with happiness and safety. There needs to be a shift in how we frame our disease. And it's very simple. Stop calling it a men's disease and calling it a people's disease.
That's great. Thank you, Daryl. Eve, I'm going to ask you the same question. What could be done when it comes to educating trans women that they are indeed at risk, regardless of other factors? And do you feel like awareness is needed here? How do you relate to this question? Oh, you're on mute.
I'm sorry, can you hear me?
Yep.
Okay. Awareness is definitely needed. And how do we do it? We reach out into the community. We reach out to the LGBTQIA plus community. We go to the community centers and we tell them that transgender men can still get breast cancer and transgender women can still get prostate cancer. And we tell them, if we're talking about a 1 in 7 number of, 1 in 7 males assigned at birth get prostate cancer. That's the old number that I'm used to seeing thrown out. That means if it's still 1 in 7 transgender women it's still that, and that's a pretty large community and becoming ever increasing. So we need to reach out to this community where this community gets their health care. And why can't we do a brochure that specifically targets trans women for prostate cancer screening?
So that's a great question. What is the main source of healthcare? I mean, I know that there is some kind of, it's an emergent area, but what is the main source of healthcare, generally speaking, for trans individuals? If we did want to go, you know, to where they are currently receiving care, those that are, where would this be?
It's going to be in the clinics where we go to get our hormones. Dr. Glass could address this much more clearly than I can because of her involvement in the healthcare network. But geez, right here in Houston, we've got a large clinic called the Montrose Clinic, and lots of people go there. But to my knowledge, nobody talks about cancer there.
Right.
It's everything but that.
Right.
And that should be part and parcel of healthcare.
Well, that begs the question, Dr. Glass, at the, you know, at the health center where you spend time that you've alluded to, are you talking about prostate cancer awareness? Is this something that is on trans women's radar?
You know, that's a great question. It's on my radar for sure. And I've got a very good primary care physician, and we do the kind of screening test and things like that. But what I wanted to add to what Eve has been saying is that we're tend to be, at least in the urban areas, we tend to be a very close-knit community, especially with social media. And it's a really common question for all sorts of things like, you know, I need a chiropractor. Who's a trans-friendly chiropractor or a massage therapist? And of course,
You have a good network has been built up.
Yeah, and so we talk among ourselves, and boy, if somebody's a horror story, that spreads just as quickly too. But when somebody's really good and they get us, like Dr. Anger was talking about, it's like, oh my God, we fall in love with somebody like her in our city, and everybody would know that's who you go to. And we do have a very good urology group here, and I'm really grateful for that. We've worked really hard to develop it, and so everybody in this area knows where to go, and it's mostly word of mouth and talking about it on social media. And then you know, as you're talking about this, I just wonder, you know, about groups like we, you know, have a band that goes around and does mammograms. Well, I don't know if that kind of day will ever come where we'll have a way to do screening and things like that. But a whole lot of trans women, though, just don't have access to insurance and their health care. Employers have gotten so much better about adding those kinds of benefits, but there's still a lot of people that just don't have access to health insurance. And those are the ones I worry about because they're really at risk. And so I don't have an easy answer to that question.
Thank you. Well, I'm going to kick it to Dr. Nakad to speak from the provider perspective. This is something I'm curious about when it comes to your fellow urologists and generally the workforce. Dr. Anger, you mentioned you work at a hospital, but have you found yourselves doing a lot of education? What's awareness like, generally speaking, from your observations, starting with you, Dr. Nakad?
Yeah, well, I think a lot of the points that have already been brought up are certainly very relevant and things that we see as clinicians as well. But I think first is, you know, taking a step back and really reframing with reframing how we think about prostate cancer, as Daryl mentioned, that it's not a man's disease and it's a disease that can affect anyone who has a prostate. And so for us, it often starts with just making sure patients are aware that they still have a prostate. You know, transgender women may not be aware of their internal anatomy. And especially after they've undergone gender affirmation surgery, you know, we still have to make sure that they know that they still have their prostate and that they should at least be considered for PSA screening. It's the same thing with clinicians, making sure that they're also aware of that risk in transgender women. And also, you know, from a clinician standpoint, increasing clinician comfort with having these discussions. and making sure that they're doing it in a respectful way that's using inclusive anatomic terminology. So, asking patients what kind of terminology they would like use when discussing specific anatomic areas. Some patients may, be comfortable calling it a prostate or very openly discussing prostate cancer, but other patients may want to, reference it a little bit differently. So I think involving the patients as much as possible in those conversations is really important.
That's great.
I don't know if you had any other thoughts on that.
Yeah, well, just to, when we talk about spreading the message, just the work that that really Dr. Nikod's led, and which has been really exciting, is identifying, like through this huge VA population, identifying what is actual risk. And then the next step, and that I'm excited, we should also give our colleagues credit to Dr. Steve Friedland, who sort of runs this whole piece, but we're collaborating on the next step. What is a normal PSA value for a trans non-binary patient on estrogen? What is the exact impact? And I think I saw Dr. Christina Jameson, who's been working on that part. What exactly does a certain dosage of estrogen, progesterone, testosterone blocker, what does that do to PSA? What PSA should we expect? We don't have normal values, right? So I think leading the way with this important research so that we can actually tell people what is normal, right? We don't even have normal values in trans women. And so, and honestly, and I think, there's this important work that she did that showed that, the numbers are so small, we don't really even know, can we say that prostate cancer in trans women is higher grade, it's worse, but we don't know because the numbers are so small. We don't know if there's a delay in diagnosis, a disparity in screening, which I think there probably is, because most women that I've seen who are over 50, I say, have you had a PSA? And they kind of look at me like, what? They obviously haven't been aware of screening.
Yeah.
And one other thing, just as a surgeon, I had a patient who had, before she transitioned, she had a radical prostatectomy. And she came to me seeking a vaginoplasty. And there's nothing in the literature on safety of vaginoplasty after a radical prostatectomy for cancer. And I had some colleagues say, don't do it, it's dangerous, it's a risk of incontinence. But then I was like, I'm going to just ask the man who trained me, and he's well into retirement, but he knows enough about these surgeries, and said the risk is probably low. And we did, together with my partner, Aditya Bagrodia, who's a urologic oncologist, we did together a vaginoplasty, and the patient actually did great. So I think as we just need more data, so we can make better, we can provide better recommendations, right? And so I think my whole point of this is saying the work, the research that we're starting to do, that's starting to be done, I think is going to give us a lot of information so we can go to the primary care doc with guidelines that say this is what a PSA should be, right? And so that's really, I think it's exciting that this is really on the forefront of research right now. And that's, I think, really important.
Now, as we're focusing on research, the idea that we're waiting is a critical thing. There are people who can't wait, and as a consequence, there are myths that float around the community. The idea that hormone changes are protective against cancers, particularly prostate cancer. The idea that different levels of transition have different risks associated with them. Well, that may in fact be true in many cases, but we don't know that. Meanwhile, until we get some good solid data and analyze it and write our papers and such, and I've got an R01 going as well in the field. It's the idea that the messaging that we should put out yesterday, is that trans women should ask not wait for their doctors to speak about something, not wait until they go into a clinic for COVID perhaps, or for an allergy. And then, as a consequence, somebody notices some other issue with their health. Trans women, just like all people really, have to be proactive and have and understand they have agents. We all have agency over our own bodies. And ultimately, we're responsible for the consequences of not being surveyed, not being treated, not going to the doctor, with the understanding in the back of our heads that in 2023, there's a lot we don't know. And treatments we may even offer today may be proven to be as effective as leeches 10 years from now. So, with a bit of humility as patients, we should go into our doctor's offices, gather whatever resources we can in terms of paying for those doctors, including doing the Medicaid and going to community health clinics, and whatever it takes to get in front of somebody with an MD or DO to get your questions answered about all aspects of your health. In most cases, early treatment is more beneficial than later treatment. Certainly that's true for most diseases wrapped around the word cancer. And, we can't, as a community, as a country, and as a civilization on the planet, we can't just wait for somebody else to take our hand. We have to go find out. And one of the beauties of living in 2023 is, whether you like Dr. Google or not, there's a lot of information online. And there are lots of opportunities to locate doctors, and a lot more opportunities to talk to doctors that aren't across the street, but maybe in Paris or London or such, via Zoom, and have consults that way. The opportunities for accelerating the understanding of your state of health in 2023 are unbelievable. And all of us have responsibility to take advantage of that. So with that respect, it falls upon nonprofit organizations, AUA, things like that, to sort of get that message out, in addition to, waiting for our research to, to harvest the good news from that.
Definitely. Thank you, Daryl. Dr. Glass, did you have your hand up? Oh. All right. The next question, and I think we've kind of addressed this in roundabout ways, but not so directly. So how does a patient's identity as transgender impact their prostate cancer care and treatment? I know Eve shared her story at the beginning, but why does this matter? And really, when push comes to shove, and when it comes to being diagnosed, and then what your options are from there, how does being transgender impact what those options look like? Dr. Nikad.
Well, I think, it starts with really centering the discussion around the patient, and really being thoughtful about how that dialogue is approached, and recognizing that, so much of what we know, in fact, nearly everything that we know to date about prostate cancer is based on data from cisgender men. So we have to recognize the stigma that might be associated for our transgender patients, transgender women who are being diagnosed with prostate cancer, and approaching this dialogue in a very thoughtful way, and really thinking as from a urology standpoint, and for primary care physicians, people who are going to be checking PSA values, really being aware of that concept of there might be delayed diagnosis in this population because quote normal PSA value is not going to take into account the effects of the gender affirmation hormones that these patients may be on. And so I think it's really important that we be very, very thoughtful about how we're interpreting PSA values, and making sure that we're being cognizant of that when, thinking about which patients need further evaluations and further workup, and what types of, next steps might come from that. And I don't know if Dr. Anger, if you want to speak more about, some of the different impacts of treatment in terms of the gender affirmation process.
Sure, that it's such an important area, and whether with vaginoplasty, we don't have much knowledge on prostate cancer that's diagnosed after. We have ability to access the prostate with a vaginal exam, and we can do biopsies to identify cancer. But I think there's very little on doing surgeries after vaginoplasty. I think there would probably be the recommendation to proceed with, let's say, radiation therapy, just because of that layer. When we remove the prostate, there's a risk of urinary incontinence, but we just really don't have that much knowledge. Another study we're doing here with our colorectal colleagues is to look at anal rectal function before and after vaginoplasty. Again, another kind of area where there's very little work done, but we think most patients actually do really well, that they're continent, right? So I think, again, getting that data, I think when someone's already had prostate surgery, if they are continent, they'll probably do well to have a vaginoplasty. And again, if prostate cancer is diagnosed later, we don't have a lot of data. And that's, I think, something that's really important to look at. Actually, Dr. Nikad, that's something we should think about doing, looking at the literature, what's out there, because I think some of these are still in the case report phase. So, but important questions to ask. I think either way, we can definitely treat prostate cancer. It's important to go to urologist, maybe radiation oncology, to know that this can be done even after gender affirming surgery. I think that's probably the best take-home message as we're kind of collecting the data on that. We need to be able to say, this is your risk of incontinence, this is your risk of trouble with, sexual function, etc.
That's great. Thank you, Dr. Anger. And Daryl, one question I want to ask you is something that you touched on earlier, where someone is in their transition and ideas around risk for prostate cancer and if you're at higher risk or lower risk, and how that comes into play. Could you speak to that?
People think that they're protected based on what their doctor is doing with them. So, Dr. Anger and Nikad could probably speak a bit more detailed than this, but from the patient, what I hear on the street, so to speak, from the support groups we lead and stuff, patients sort of use the idea like, well, I haven't gone through gender affirming surgery yet. So, maybe I don't have to worry about prostate cancer because nobody's touched the inside of my body, which is, a ridiculous myth to think like, not having surgery keeps you from having prostate cancer. No one would get hernia surgery if that were the case. The idea that people who have gone through hormone manipulation or treatment of various kinds can be protective. That therapy can protect you from prostate cancer. I've heard that from as recently as a month and a half or 2 months ago from a prominent urologist, who in the middle of our country at a major city, who was very frank in saying that trans women don't have to worry about prostate cancer because of the therapies they're undergoing. And then he went into more detail with me, and it was like, show me a paper, anything, it's like insane that people will spout these fantasies and project them into individuals, lay people, as truths. And then that sort of myth making, that toxic myth sort of spreads because nobody really wants to be treated for prostate cancer because of the side effects of erectile dysfunction, urinary incontinence, lethargy, fatigue, the whole gambit. It's not like getting your tooth pulled and then the pain goes away. You may have a hole in your mouth, but you could deal with that. So any excuse to avoid prostate cancer, that's a pole that heterosexual men grasp on, as well as transgender women, and everyone in between, non-binary folks, everyone. Everyone would love to have a reason not to have prostate cancer treatment, even if indeed you have prostate cancer and it's life-threatening. The idea that we should just, like, in 30 seconds or less, just mention intersectionality. There are African American transgender women, there are women on the down low, there are women who will present as if they're in a heterosexual relationship, and the doctor may not be cognizant of what's going on because that's how that patient is presenting and wants to be thought of. There are opportunities beyond misgendering for mistreating a patient, or not understanding the impact of racism, homophobia, disparities of all sorts on individuals. And I think we just have to, gear up our frame of minds when meeting with patients to say, here's my internal checklist. I ought to run through it with this patient because I want to know who they are and I want to take good care of them. So, long story short, around levels of treatment, just like Dr. Nakata and Anger and, pretty much all of our colleagues will tell you, we just don't know enough really to answer that.
You've got to reestablish the baseline, all the more for more research, which we'll get to. I'm preempting the next slides, but Dr. Glass, you've had your hand up.
Oh, yeah, thank you. Well, it's along the lines of intersectionality. And when you ask this question, it's too easy to think in terms of just physical transition, like how long have you been on hormones and have you had electrolysis and how well are you passing and those sorts of things. But I wanted to go back to the emotional aspect, and especially for people that are in that age group of their 60s or older. We've hated our bodies. We haven't wanted to take care of our bodies. Because they were a source of torment. And so when you find out you've got prostate cancer and you've got to make a decision, like, how badly do I want to live now? And so, when you're trying to struggle with all of that and then you go into an office where they're going to misgender you, it's like, oh my God, I think I'd just rather give it up now. And so it's another aspect of that intersectionality and why the respect and dignity is so important to these people, and to not just be misled by their physical appearance too, because there's a whole lot of baggage that goes into living your life under compulsory masculinity, I call it. It's like it just wears you down so badly. So anyhow, I just wanted to add that point too. It's just another reason to be so respectful when you have these fragile people in your office.
Thank you, Dr. Glass.
Yeah.
All right. So our next question: in cases where a urologist feels ill-equipped to treat a transgender patient, either for lack of experience, expertise, or their own comfort level, is there a protocol or a standard for making referrals? I mean, I think that this was touched on earlier, where these networks, Dr. Glass, you mentioned that, you develop these local networks of people to go to, people not to go to within the trans community. But from the provider side, because I'm sure there are those providers who are not comfortable or don't feel that they have the competency to treat trans patients. What happens to those patients and what does that look like? Dr. Anger.
Can you repeat that? I'm so sorry. I had a little glitch in my.
No, that's okay. And it could go to Dr. Nikat either, but in cases from the doctor perspective, in cases when a patient presents as trans and the doctor doesn't want to treat the patient or feels they can't treat the patient, I mean, do they have a short list of people typically, or most of the people you see, are they referred out after seeing someone else? What does that process look like?
This is a real, this is sort of getting to barriers to care. What we find for gender affirming surgeries, as patients often have to travel, and it's getting better now that, with the Affordable Care Act, there's a huge surge of centers that are doing gender affirming. I'm talking about urologic, so bottom surgeries. So we have a lot more sites, but patients still do have to travel. And often, let's say if they have a complication, so let's say a stricture where they have urinary difficulty, and they may go to a local place. And urologists can always manage emergencies with, if there is a stricture and they can't void, a urologist could do a suprapubic tube. And I think the biggest, what there is a problem is I think when you see people afraid to manage the complications that we see just because they don't understand the surgical anatomy maybe, or what has been changed. I think it's important that just to, like Dr. Middledorf said, how do we be nice? How do we say, let me try to help you? And then that's like a huge, because all emergencies can be helped, even if someone's not an expert in gender affirming pelvic surgery. And then otherwise, I think usually, and I think it comes from communities who care for trans patients, they have a go-to list usually, for affirming care. So people will know where to send, like usually again, the providers who give hormones to patients, the providers to that see a lot of trans patients. They usually have like a list. And I think maybe many urologists don't, who in a general practice may not necessarily always have that list. It tends to be in a local LGBTQIA center, right? But I think
it sounds like that's an option. That's a great thing, right? If more offices just had that list, they were better able to direct folks, Yeah,
and also we have now at the American Urological Association annual meeting, there are courses there that is transgender care for the general urologist. So ways to be able to kind of be gender health friendly, even if one is a general urologist and not necessarily specializing in bottom surgery.
That's great. And a great plug for our annual conference. Thank you, Dr. Anger. So I'm going to take it to the next question, just in the interest of time here. And this one is for Dr. Nikad. So we talked a lot about, needing to establish a baseline, the need for more research when it comes to trans women and prostate cancer risk and treatment. So in the context of advancing this area and our understanding of the unique considerations within this patient population, can you speak to any areas of clinical research and any ongoing areas of clinical research and the need for patient engagement and participation, and any remaining challenges? I mean, you opened us up talking about your excellent work, and it sounds like it's still very much alive and active and going. So if you could speak to those things.
Sure. Right now we are very much still at the infancy of our understanding of prostate cancer and transgender women and how best to care for our transgender patients. And so this is a very wide open space, and one that, our group is very passionate about. I think some of the main challenges are, one, establishing what baseline PSA values are for those who are on gender affirming hormones. That is a function of both the type and the duration of gender affirming hormone therapy that they're on. What is an elevated PSA in transgender women? Because it's not 4, which is the standard cutoff that has historically been used. So we have to really carefully define what we're considering an elevated PSA, since that number will determine so much of the subsequent workup and is something that's going to be used by so many different clinicians. Some studies have suggested using a cutoff of 1, but this remains to be better established. Additionally, we've touched on it, but transgender women are excluded from all guidelines from major organizations. So we have to create guidelines that are inclusive of and specific to transgender women on gender affirming hormones. So, some of those things should include, how do we define what best PSA screening practices are? How often should we be screening transgender women who are on gender affirming hormones? How do we time the screening in relation to those who are maybe, starting gender affirming hormones a little bit later in adulthood and who would otherwise be considered for PSA screening? How do we time that in relation to their gender affirming hormone initiation? And then also, thinking about how do we not stigmatize and re-stigmatize transgender women every time they're going to undergo PSA screening? So how do we approach that dialogue with our patients? And, some of that work, I think, would really benefit from direct input from our transgender patients. How would they want their clinician to approach that dialogue with them. How do they view PSA screening? How do they think we should try to decrease some of the psychosocial barriers around that? And the other factor, and something that was very interesting from our work, was that we only had 6% Black transgender women. So understanding what additional barriers exist at the intersection of gender identity and race, how best to address some of those barriers. And finally, just going back to it, ultimately, we really have to just reframe how we think about prostate cancer. It's not a disease in men. Transgender women are still at risk of prostate cancer. And so we have to reframe how we think about it as a disease in people with prostates.
Thank you, Dr. Nikad. That was a great answer.
Thank you.
Okay, and I feel like we have already addressed this in various ways, but there is this idea that this population hasn't reached critical mass. Maybe there's no prostate cancer risk in trans women, even though we've established that's bunk. But to those who don't feel that this topic is necessarily something of elevated importance or something that rises to the top in the prostate cancer space, what would you say, Dr. Nikad?
I think it's important to recognize that even though transgender women may not be, the majority of the population, they're still people. And we should recognize them as people who are deserving of care and deserving of research and, the benefits of research, all the knowledge that would be gleaned of that. And to also recognize that transgender women and people openly identifying as transgender has continued to increase with time. And so we owe it to all of our patients to be able to care for them in a way that specifically factors in all of the nuances that, that would go into their care. And so I think it's just recognizing that they are people too, and that we should be caring for them.
Thank you. Daryl.
Yeah.
Turning it over to you.
So challenges that remain. How to recruit LGBTQ people into studies and such. I mentioned I'm an investigator on an R01 that's and it just entered its second year to understand how best to recruit LGBTQIA people into studies and such. But I think ultimately it's about, everyone understanding healthcare belongs to all of us. And we have to sort of take agency, back to what I was saying before, for ourselves, and to seek out doctors that can care for us. The idea of inclusivity, there are going to be, I think we have to deal with the reality of 2023, and perhaps for the next 5 or 10 years, there are doctors who are going to struggle with treating gay, lesbian, transgender, bisexual, queer, but non-binary people, whether we want them to feel, culturally competent or not. And the opportunity to refer out, as we were touching on earlier, is a good sort of way to get people into treatment, into care, and ultimately into improving our understanding on how best to treat people who have gone through gender affirming therapies and treatments and surgeries, et cetera. The idea that cultural humility and inclusivity, that we could teach this, it's nice to think that, and there's, there are a lot of nonprofits that make a good business out of that. But the reality is a 3-hour, continuing education course is not going to take a bigot and make them into an angel. It will just give them perhaps some facts and figures, but it's not going to change the the acute way they handle patient-doctor interaction, their own sort of soul interacting with another human being sitting in their office, or in their actual concrete care during a particular therapy or treatment. The opportunity to understand and accept that there are people who struggle with people who are not like themselves, I think is a golden opportunity to get people into better care and to show respect to those who are not quite sort of, dare I say, woke to the idea that everyone is a person. I think it was Dr. Glass just now that said something to the effect, we should treat everybody as people. Whatever. Everybody was a baby, at some point. I mean, I dare any doctor to look at a baby and say, I'm not treating that, a pediatric oncologist, I'm not treating that because I get a sense that child's going to turn out to be transgender or something. That would never occur in Klan meetings and Proud Boy meetings and whatever you have. The idea that we have to understand that there are members of our colleagues, of our healthcare provider community, that in our lifetime are not going to get there, are not going to get cognizant that people are people. And we just have to accept that to some extent and, try to educate, empathize, what have you. But ultimately, we want people to get cancer care and all sorts of other care, but cancer is what we're dealing with. We want people to get into treatment that's appropriate to them, and we want them to be treated by the most capable and caring physicians that are out there. And that only comes by just accepting the fact we're all human. There are hundreds of thousands of people that are more fallible than others. And that's just the state of humanity as it exists today.
Thank you, Daryl. Dr. Glass, do you have something to add?
Oh, I do, and I can't believe I forgot it. I mentioned that directing our Transgender Wellness Coalition, that's been going on for over 10 years. And we began developing a provider directory, medical and mental health, and then related services. And that's just grown and grown. But my point is, probably everybody watching this was city name, pride group, and those groups that try to serve the whole LGBTQIA community have already been developing directories. And if you're a provider that would like to have them know about you, they'd be glad to add you to that. But it's also, if you're somebody looking for who else in my community can point me in the right direction and get me better equipped to deal with these kinds of patients, that's where you're also going to find the physicians and surgeons and hormone replacement therapy people, all that stuff. I just wanted to mention, check out your local pride group, because they have a chamber of commerce. They have directories for everything you can think of.
And I'll just add that I think at least when I came here, most of my colleagues, especially the urologic oncologists who want to treat and do a good job treating prostate cancer, they've all been very supportive. And I think that for people who are maybe not as, don't have as much experience with the population, many want to help. And then those who don't, we just don't worry about, I had someone say, you're not going to, that we don't have to worry about convincing the people who, are not in supportive of the cause, right? But I think most urologists do want to help. And I think it's kind of just giving them the tools so they're more comfortable helping, I think is an important piece.
And one thing, Dr. Anger, at the beginning of this, you mentioned one such tool, a training for providers. Was it I don't recall the name. I thought What was that training?
So there's the World Professional Association for Transgender Health.
Okay.
And that's the large organization that really developed what's called the standards of care, which, help basically provide affirming care and guidelines for affirming care. And so through WPATH, we have a global education institute that gives trainings, right? But any of us, for example, who can provide a training on making your office inclusive, right? So, so really and usually most hospitals have a, DEI committee, people who are trained at providing information to different offices. But the WPATH is also a resource, let's say, for a private office who maybe isn't kind of part of a big healthcare system like I am, for example.
That's great. WPATH, thank you. Dr. Glass.
Oh, yeah, I just wanted to amen that recommendation, WPATH. They even have a search feature. If you put in your zip code, and if you're looking for a medical health or mental health provider that has made themselves known, or you want to be a part of that organization, it's a tremendous resource, and it's just growing by leaps and bounds. And they're very, very good at what they do right now. And so I just wanted to second that recommendation. It's a great group.
Another source of training, so to speak, are patients. I mean, it's good to have formal training, et cetera. And I'm not familiar with what's being discussed with the particular training, but I've sat in or taken many. They're okay. But when a doctor reads that a patient felt fear, or as Eve said earlier, that she felt like the needles of death or what have you, that sort of resonates a lot more than a statistical analysis of how many transgender people are in per zip code or whatever. I mean, these trainings are much higher quality than what I just alluded to. But the idea that people speak their own truths, and doctors, so like we have these online support groups since COVID. Doctors were invited, quarterly, once every 3 months, give or take a few weeks, to sit in, quietly, and just listen. And the participants were aware that there were physicians listening. And the things that were spoken during those sessions were extraordinary, things that surprised me. The grasp of emotional depth that patients have about their own health condition and the struggles they have in wanting to share that with the doctor, the fear that they have that if they say the wrong thing, the doctor's treatment may reflect that wrong thing, may vary and go in a negative sort of way. I mean, even to the point where, there was one patient, a radical prostatectomy patient, maybe a year out after their treatment, who was, he was suffering erectile dysfunction, from his point of view, complete and unalterable. The idea that by coming out to his doctor as he did, as a gay man, the doctor purposefully caused him to be impotent. Obviously, probably completely unimaginably not true, but that patient now suffers that insult to his emotional life, and probably for decades to come until his death, because of the ways doctors may interact with patients. So in addition to all these wonderful trainings, doctors need to ask and open their ears and then just think about what their patients say to them. And that, I think, is a good form of training as well.
Thank you, Daryl. And a powerful note to end on. We have a couple more minutes, so I'll turn to the rest of our panelists, see if anyone else has anything else for the good of the order. And any questions we got, if they're good, we will follow up with answers in the bundle of materials we send out to registrants. So before closing out, any of our panelists want to offer up anything beyond what you've already offered, which has been wonderful? Dr. Glass.
Yeah, well, anybody that's watching or in the future, I just really want to commend you for being open-minded and spending your time with us, because we do deserve excellent health care, and we're going to get it. I haven't got anything to say about it, but thank you for having us, and thank you for watching this. It's important to me. So.
This has been a pleasure to participate in this kind of a dialogue. And if I had words to leave people with, urologists specifically, pronouns. Right. It's not that hard. Be inclusive, be aware, and
A formidable call to action.
Other medical details, just get your damn pronouns right and be more others. And if we can do that, then we've made a major step here. Go ahead, Dr. Enger.
Oh, no, I was just gonna say, I totally agree. And I just loved what Daryl said. Like, it almost brought tears to my eyes. Just be nice, right? You try and to be nice. That goes so far in life, right? But it just really hits home with regard to caring for people who might be, a little different from us, or people we haven't met before. And I think that's so much of the problem with which what we see is people, what they don't know, they tend to judge. And I think that whole concept is so important.
Thank you, Dr. Anger. And thank you for helping us shed light on today's topic. Anything else from our panelists? No? All right. Well, thank you, everyone. On behalf of the AUA, UCF, and PCIA, thank you for an excellent webinar. And this will be posted on our YouTube page, so you can look for it there. And we will follow up with the link once it's up. Thank you.
Thank
you
you
so much. Thank you.
Thank you for highlighting this topic.
Thank you.